You're good to go.
Okay, great. It's only just noon, so maybe we just give them another minute or two. And particularly, it'd be nice to see if Jen Philippone, my co-chair, is joining. I haven't talked to her in a few days, but hopefully she will be joining. All right, good. I see. It's like Jen is signing on.
Hi, everyone.
All right. It's like we have Dr. Senator Anwar and Representative McCarthy-Vahey. Glad to have them join. Thank you. So it's 12:02. Jen, are you ready to convene the meeting? Can you hear us okay?
There we go.
Okay.
Apologies, not my friend today. Apologies, everyone.
No problem. And I know we're getting closer to the holidays, so I'm glad that everybody could make it to this meeting. We really appreciate it. We did want to, the first item was actually if there's anyone who's new to the group who hasn't joined the last two times, if you could just raise your hand and we'll introduce you. If not, if everybody's been here before, then we can go on to the next thing. All right. So everybody's been here before. So the agenda, I know we just got it out this morning. It's fairly open-ended. We did spend the last 2 weeks trying to survey the members, and I put some results of that together this morning to share with the group. I don't know how long we'll talk today. We don't have a lot of detailed agenda items. I believe the survey gives us a lot of things to spring off of and to discuss. But I really want to encourage everyone on the group to really try to be actively involved in this discussion. We certainly have time if you want to pause and emphasize something from the portion of the survey, if it wasn't asked correctly, if you want to clarify any responses. And then at the end, I think we can circle back and touch on some of the issues overall for the group moving forward. Does that sound like a plan? Okay. Let's see. So hopefully I can share the screen here. Can everyone see this screen?
We can, thank you.
Okay. So this is the survey. It's fairly informal. It was done, for the work group members. We had about a week to do it. We got 18 responses. I think our group is about 22. So I think it's a pretty good response rate for the group overall. There may be a few people who didn't get a chance to do it, and certainly if you didn't get a chance to do it and you want to weigh into this discussion, we'd love to hear what you had to say. The first question was to rank the overall categories in a sort of big picture sort of way about how our work group members perceive the issues of getting patients out of the hospital and what are the number one things. And the top two are fairly close. We did rankings and I kind of averaged those. One would be the highest rank, and in other words, the most important. And the top of that was funding or insurance issues that limit placement in appropriate and available environments at 1.8, meaning, at least as the way the question was phrased, that there are environments many times that are available and that could be the right place for the person, but it's actually funding or insurance issues that are causing the problems. So that was rated as the top issue for people, and we've certainly heard that in other places that payment reform is maybe the top issue we need to really emphasize at the state level. The second ranked one of the big picture things was lack of availability of an appropriate post-acute care placement environment, and that included home setup, and that was an addition I'm trying to remember which work group member specifically asked for that. But we aren't trying to say that anybody has to go to a skilled nursing facility or that has to be the place. I think we just want to talk about availability of appropriate post acute care placement environments, and that would include home setup, so home care. And there were some comments we'll talk about a little bit later in the work group about maybe how to expedite or facilitate that. The other ones came in fairly far below as far as the rankings. Other discharge challenges, transportation delays, patient-family cooperation, care coordination. And then I was a little surprised actually that people did not rate conservatorship or guardian issues as that highly. That's something I've heard about just anecdotally as an issue, and perhaps it doesn't really affect that many, but it wasn't ranked as highly by the group. So I will pause there. If anybody has any questions or comments on this, just please raise your hand. If not, we can continue to roll through the survey results, but I would like this to be a discussion if possible. Another Anwar.
So I think that was an important part of the question. I think at any time in the hospital, there may be one person, so the volume is not as big as the process is. So it does not necessarily take away from the value of this issue, but thankfully the volume is much less. And for the other issues, the volume of and the impact on the entire problem is far more. So we should address this perhaps, but it's not like one of the top things.
Yeah, that's a really good point. In the survey, we didn't necessarily try to discriminate sort of, there can be issues where you may have a few patients that are waiting for several months. And then you have, dozens of patients that are waiting for several days. And so the actual weight of the, various challenges could be a little bit different, even though the number of patients that it's affecting could vary. So we did not try to parse that out. But I think it's a really good point that some of these challenges are still important, even if they don't affect quite as many patient days. So thank you for that. Any other questions or comments on big picture?
I think it's Hasnain here from St. Mary's. And I'm wondering whether or not there's any comments with regards to low-lying opportunities that we can tackle in a more expedited manner, which again may help decide which one way or the other we rank as categories. Certainly, I had trouble setting up like 1, 2, 3, 4, 5, because some of them started to merge together as issues along the way.
Yeah, are there any particular low-hanging fruit that you're thinking of when you're saying that?
Well, I think when we think about lack of availability of appropriate post-acute care placement, from experience, which is an end of one institution, I think some of our challenges include the variation that occurs with respect to things such as infection prevention, or even some things as simple as dare I say insurance agreements from the post-acute cares. I think if we had more standardization across those pictures, it being flu season, for example, the question about which facility requires a post or a flu test and how many days after they were first diagnosed as flu before we can accept them, those become challenges. And I believe areas where from a group perspective we can help coordinate some of those things. Transportation delays is another area where, again, some facilities are able to move people back and forth between facilities. If we can figure out a way statewide to ensure we've got good setups so that patients can mobilize between facilities and, say, radiation centers so that they can continue those pieces. Those are some of the simple barriers I think that we might be able to coordinate across the state that allow us to move these pieces forward. Conservatorship guardian issues, those are a little bit more tricky because a lot of that requires, even if we have a good process in place with good partners, it still requires a lot of work between getting paperwork from families and going through some of those pieces.
I think those
And
are
then, from a conservatorship, of course, the challenges in the court systems of getting time and on dockets to get that clarified.
regarding some of your ideas, standardization or transportation. How would you operationalize that at the state level?
Well, I think if we had a mechanism by which the facilities could tap into in some of the more challenging situations, or at least a degree of coordination on those transportations, so that there becomes a single point of contact or a simple call where things get distributed from there, as opposed to everyone sort of doing their own thing. It seems like that variation, opportunities to reduce variation, could be the right setup. Certainly when we sometimes press outside of transportation, sometimes we press on our post-acute cares, depending upon who we get on the line, we're able, if we talk a little bit higher level, challenges seem to evaporate and we're able to bring them home, get patients discharged. So I think, again, that standardization, making sure everybody's on the same page with those pieces. And if the state could at least facilitate those so that we're not doing it individually and we're all in agreement with what those standard procedures could be, maybe a step.
Yeah, would that be like through DPH, or how would you actually do that as far as a mechanism?
Yeah, I would think through DPH. Certainly when we engage the ombudsman at the facility level and on the outpatient facility level, they seem to do a great job of holding our facilities accountable to what has been agreed upon. And that's helpful. But again, it's that extra step that we sometimes have to take.
Go ahead, Jen.
So I'm wondering if, as we talk through, some of these where we identify, kind of the higher ranking, if you will, if there's an opportunity to have a more substantive discussion. If we use transportation, right, as the example, to understand the issue a little bit better from a statewide perspective, what a legislative, right, because that's what we're talking about here right now, whether there is a legislative remedy or not, and that would help us understand whether to keep it in the immediate, right, of this focus of this work group, or if it's within the scope but outside of what we can control. That will help us to prioritize, I think, what we try to tackle, and understanding what the problem is, right? I think that might be a way to approach it. Because I'm going to guess Lorraine's going to say, I'm not sure it's DPH. It might be DSS, right? Right. When we're talking about, again, that post-discharge, because we're talking about non-emergent patient transports. We're not talking about emergent or intra-facility, right, from an acute care standpoint. I just want to make sure, I'm not going to disagree with you about all your comments about those opportunities potentially for standardization. But again, I want to make sure that this group stays focused on what we actually might be able to accomplish, right, with the help of the co-chairs in a legislative session, not to forget about the discussion, though. Lorraine?
So that is partially what I was going to comment. I think it's, when we're talking about non-emergent transport, I think that's a conversation bigger than DPH. I think that's a multi-agency conversation based on, as you said, DSS, based on payer source and based on who's coordinating that non-emergent transport. We do have a part more in the emergent section with our oversight of EMS, but we'd be happy to be a part of that. But I think it is a greater conversation as to how to impact that.
Senator Almore.
So I'm going to give a broader overview and then come back to the non-emergent transport as well. That's a separate conversation. So healthcare evolution in the last many years has moved towards the hospital setup and hospital settings and the emergency departments to be providing immediate care that's necessary, and then transitioning the patients to the appropriate level of care. And when I say appropriate level of care, what used to be 15, 20 years ago in a rehab facility is more of a care that we were getting in the hospital before. So you actually have created a pipeline. We have collectively created a pipeline where the patient would be in the intensive care unit and they would get their care. As soon as they're stabilized, they would go to a step down unit, and from the step down unit, they're going to go to an LTAC, or even from the ICU, go to an LTAC. We do not have enough LTAC beds in the state of Connecticut. As I speak to my intensive care unit doctors across, they actually stabilize the patient, put a trach on a ventilator patient if they're going to require a trach, and then move them to an LTAC. Like in 5 days, they're out of the ICU and out of the hospital too at the same time. We don't have that pipeline in the state of Connecticut. We have actually been reducing our even acute care rehab beds in our state as well. So as a result of which the pipeline is going gummed up. The entire system is gummed up because of that very reason. But we need to have some kind of a policy to be able to get higher number of acute care beds in a rehab facility, or like Gaylord is one place that we can actually get people, or hospital for special care. And then outside of that, we are just stuck. We go to Springfield for some of the complex patients as well. And so while insurance is part of it, there is a lack of enough beds in those facilities. And I think that's where we may have an opportunity. So the insurance part can be made more efficient, and then they can actually fight some of those battles, and that's where the insurance department or other things can help us out. I don't think the insurance part is going to be a legislative issue, but there will need to be investments in much more LTAC-like facilities in the state, because I visited Gaylord, and they are financially struggling too at this time, because they're full, but the payment is not enough for them to be able to do well. So that's part of the reason with the Medicare and Medicaid funding that has resulted in them restricting themselves from expansion. So just some money issues as well that are part of the problem of why we don't have enough beds for discharge. And for the non-emergency medical transportation, both Representative Kristen McCarthy-Vahey and I can be helpful. We are co-chairs of the MAPOC, where that actually is the DSS, where we are able to look at all the services that Human Services and Department of Social Services is able to provide. We can actually be helpful to reassess that. But for people, if you can track anytime those efficiencies are there with the details, let us know, and we can actually try to get back and work with DSS and the vendor that we use. Thank you.
That's great. And Marcy, I know you had your hand up. If I can jump ahead of you just for 1 second. Understanding too some of the new beds that are coming into the state. So there is a new facility that's going to be opening in Waterbury. I'm not sure of the timeline. I don't know, Lorraine, if you have that information yet. I think it's Pam. That's going to be looking more like an LTAC, I understand. And then in addition to the few of us that have acute rehab units, Encompass Healthcare just opened in Danbury, and there's, I believe, another site that they're going to be potentially opening in the state as well. But to your point, Senator Arnwar, the beds aren't there today, right? It's what are we going to do until they're there, and then how do we facilitate some of that? So thank you for raising that issue.
Marcy, did you want to comment? I'm sorry, she had her hand up, but then it came down.
I did briefly, and then I feel like it's more of the same. So I didn't know if it was worth everyone's time to kind of pile on or or not. As far as the example of like the vent beds, I do believe that there is likely a shortage of vent beds, but in addition, even just thinking about Medicare versus Medicare Advantage. Gaylord is a great example of this. You know, Medicare Advantage will not cover a patient to be weaned in an LTAC, right? So they have to they won't pay two different providers for the same service. So if they've already been vented in a hospital, there's no place to transfer them and still be able to be reimbursed. Whereas that is not necessarily the case with straight Medicaid fee for service. And so I do think that there is probably a place there to kind of provide some pressure to make sure that even though it's paying a second provider, it would be likely paying them at a lower rate than continuing to try to pay, an acute care hospital. And, as we've talked about, would free up capacity because that's one of, vents are one of the longest stays.
Did you
in
mean
a- in a-
Medicaid or Medicare Advantage? Because you said both.
Oh, sorry, I said Medicare.
Okay, it's not true that Medicare Advantage doesn't pay for weaning and LTAC. This is Kirsten Anderson from Aetna.
Okay, I mean, maybe that's something that we can clear up. I'm hearing from the LTACs that they're not receiving payment or they're being denied when they try to take patients out of acute cares.
Okay,
Maybe something we can follow up on. That would be great to clarify.
that'd be great. These are just some comments on other overall issues. Don't know that we need to dive into detail on all of them right now, but people talked about behavioral health causing particularly long stays. I thought it was kind of interesting that high medication prices could be an issue with capitated care. So some of the places may not be accepting patients that have a lot of medications that are going to be super expensive. Not sure how much of an issue that is, but it came up. There was the issue raised of how to quickly set up services, and we'll come back. There was another comment on that as far as a possible solution. There was comment about pressure to discharge patients resulting in a higher percent of patients going to SNFs. And I have heard that in Connecticut. Again, it's hard to get data on this, but anecdotally that, Connecticut is using SNFs at a higher rate than other states. The next question on the survey was the importance of specific issues. These were ranked on a scale from 1 to 10. It wasn't, I guess not ranked, they were rated. So the higher the average, the more important the group thought that they were. So I'll just roll through those. Topping out the list was Title 19 or Medicaid delays, rated about 8. Next was timing of acceptance. We phrased this question particularly, evenings and weekends if somebody's trying to get a patient accepted for discharge and they can't do it because it's Friday at 3 p.m. Lack of availability, we talked about that as a big issue, was rated 6.9. Insurance and pre-authorization delays, 6.8. Home environment not appropriate, 6.6. Family readiness, support limitations, 5.9. Transportation challenges on there, a little bit lower. Homelessness, 5.5. Conservatorship, guardianship issues, 5.5. Coordination of care, 5.4. Undocumented immigrants or no payment source was not super high on people's radar. So again, I'll pause here, and if people wanted to comment or provide any clarification about some of these more specific issues that were felt to be of importance for the group to look at. Senator Anwar.
So I did not realize that Medicaid delays were such a big issue collectively, but if that's something that we as a state can do something about. So we can have a conversation with the Department of Social Services who actually oversee the Medicaid part. So I think that's an area of opportunity that we can look at. And that's probably maybe a conversation versus a legislative fix. We can look at those aspects on that part. I just wanted to make a comment that depending on who you're speaking to, there are people that I speak to, they feel that anything and everything that has ever gone wrong in healthcare is because of undocumented immigrants. And it's good to see that people recognize that that's not as big of an issue, where there are people who just believe that that's the only issue. Just saying.
Thank you. Tracy?
You can let Rep. McCarthy Vahey go next, and then I'll go.
Dr. Morris, may I be
Of course.
recognized? Thank you so much. Tracy, thank you for that. I appreciate that because my comment actually is to follow up on Senator Anwar's. I was thinking the same thing as he was saying, and then also wondering if folks may comment on the Medicaid delays. a little bit more specifically about that. Is that on the state end, or one of the things that I know we've talked about in the past, and certainly Senator Elmore has, as a longer co-chair of the MAPOC group, is the difficulty in getting approvals and the difficulty in getting everything in that's needed. And I'd love to kind of break that down a little bit to understand more about what's behind those delays. And I know we've talked about that here, but just having a better handle on that so that we can make sure that we're intervening and hopefully helping in exactly the right way and the most effective way.
Thank you. Tracy?
Yeah, thank you. So I'm going to go over a few of the top three. The lack of availability for post-acute care beds. Just want to make sure everybody's looking at this holistically, post-acute in general, because we don't often talk about beds when it's home health. We're trying to place people in the community. So I actually ranked this fairly high. But I captured the home health capacity under beds, just so people would know. And then timing of acceptance and the payer piece altogether, I think are aligned in the sense that agencies, home health, and not so much hospice, but home health agencies unfortunately only have so much capacity, and they may not be able to take the reality. They may not be able to take some of the Medicaid clients into the community because they've already maxed out with what they're able to take and still at least be able to sustain their agencies financially. The reality is tied back to the first question of the survey in adequate rates. So that's one thing that I think is extremely important to note. The insurance delays, not so much, but authorization for what's really needed versus what is authorized is a challenge. And then trying to make sure that the people that are leaving the hospital or need to leave the hospital have a process in place for eligibility. I think that's a big challenge. Agencies aren't able to take the risk of taking somebody on that does not at least have something well underway for eligibility application. So I think all those areas are key for transitioning into home care for the community.
Tracy, can I ask one clarifying question before we go to the next, or maybe it's more of a comment, right? When we think about the workforce also, right, is in home care's ability to take on new clients, right? There's some very strict standards, right? So you can't even accept, it's more of a comment, I guess, to have you validate than a question. You can't accept new patients if you don't have a staff person to actually take on, right, that volume.
Correct. We're supposed to be transparent as to the ability to take on a case if it's got multiple disciplines for therapy and we don't have access to, say, an OT for another week or two. We have to let them know that we wouldn't be able to take that case on.
Thanks.
I guess also just to follow up on this, I mean, aside from having the actual people to do it, is some of it, I mean, one trend that's come up when I've talked to people about this is presumptive eligibility. And I know there were some efforts at the state level, I think passed in fall of 2024 regarding home health care and presumptive eligibility. Is that something that's happening or?
It's supposed to be in process, but I'm not so sure it ever really took off. And it's primarily for the Connecticut Home Care Program for elders. And it's not for someone who might have an acute situation in the hospital transitioning to home.
Okay. Is there work that could be done in that area regarding presumptive eligibility, you think?
I don't know that it would really impact the population that we're discussing here.
Okay. All right, interesting. Mag, go ahead. Thank you.
Sure. Just following up on what Tracy was talking about. I think some of this is that when someone's being discharged for post-acute care, and Medicare is going to cover them, there's always the risk they're going to then stay, right? If they're coming to a nursing home, if they're going home and they're going to need extended long-term services and supports that aren't covered by Medicare, and then that's Medicaid. I think the delay that people are talking about here is the delay to get someone qualified for Medicaid. So it's not the payment from Medicaid, it's someone coming into the potential long-term services and supports arena who isn't yet Medicaid qualified. So they haven't gotten their eligibility. It's a 5-year look back. It's just a very extensive process. So I know DSS is in the process actually of trying to streamline this a little bit, but it's just a tedious process. And it's a risk you take if you take someone and now you got a 5-year look back and nobody's going to help you file that eligibility, the application. It's all under federal rules and it's a very difficult process. So I know that that comes into play sometimes. So it's not necessarily that Medicaid's not going to pay you. There's a delay in payment. It's more a delay, I think, in the eligibility process. And it's just, it's just a creature. It's just a fact that this 5-year look back is difficult.
Is that a situation where there, could potentially be a state fund that would cover things if they weren't they're made presumptively eligible and you get your ducks in a row, you think they're going to get funded, but they don't have it yet. Can you put it in place sort of a state safety net for that?
Well, you could, but it would be all state funding because if someone does not then become eligible, who's going to pay back that fund? If they become eligible, you could pay it back and then the state recoups, right? But if the person is not eligible or they have a penalty period, and that's the other thing, if someone has transferred their assets or something and gets a penalty period or does not get qualified right away, then there's a period where the person's not going to get paid. The nursing home, the agency, whoever is providing the long-term services and supports. So while the state could do that, it would be really risky for the state. I would love to see that. I think it would encourage people to take people, sight unseen. But I think that could potentially have a big price tag on it. I don't want to talk myself out of having this answer, but and the other thing is this: the federal government says that you cannot require a family to help with the application. So that puts us back. That's a recent thing, a recent CMS rule. You can't have someone guarantee a nursing home stay. But you could always say, but you got to help us file this application, right? And you have to go and you have to help us pay out of their funds, the residents' funds to pay for the stay, when you can't do that anymore. And there's also just going to be a 2 months that they go back to, a 2-month retroactive payment as opposed to a 3-month. And so there's a lot of things in there that are actually working against us on the federal level.
We'll have Representative McCarthy-Vahey jump ahead real quick, if that's all right, Ted.
Thanks, Dr. Moore. I guess I just wanted to say, Mag, you were speaking to what I was touching on earlier, and the funding piece is a real question/concern. And I think my question is, what do we do in the face of that? I mean, this is another one of those situations where the federal changes are really tying our hands in ways that are having tremendous impact on this issue and so many others. So I guess that's something that I'm interested in trying to understand. Are there other ways, to Senator Anwar's point, are there other ways and there are other things that we can do about that? And obviously, Dr. Moore, I don't mean for us to deeply dive into this now if you don't want, but
I'm happy to respond. Just
to get a toehold on a solution. I mean, I guess the thing that appears to me is that, yes, there's a cost to the state, if you're funding care someplace else, but collectively as a state, if we're paying for patients to be in the hospital, that's more expensive than it is to get them in another facility. So I think thinking about it from that perspective, might be helpful.
And if I can just add to that, Chris, when you think of and I don't have the solution either necessarily, but when you think about that extension of not only is it a higher cost to be in the acute care setting, again, I'll go back to something we talked about at our first meeting. It's a higher risk, right, to a patient's safety and quality of care the longer they stay in a hospital. None of us like to talk about this, but they're at risk for a fall. They're at risk for a hospital-acquired infection or something like that. So that the cost of that is substantial as well.
Thank you. Ted's been very patient. Ted.
I mean, I guess I'd be curious to what other institutions' experience are. For the last, I would say last 2 years, it seems like facilities are no longer willing to take people with T19 applications that are pending, even we have a copy and it's like as clean as could be. And I'd be curious to know if something happened in the reimbursement model where, why did all of the facilities seem to slowly one by one stop taking these patients? And they won't, now we have no, I can't remember the last time we placed a facility. We placed someone in a facility with a pending application. You know, they're all making us wait until it comes back, which dovetails into all the processing time and the complexities there. But it seems like something must have changed. But I'm thinking something changed because it's just been such a dramatic change. I don't know if anyone has any thoughts on this.
Don't know if anything's been changed. I work with some of the nonprofit nursing homes, but I know that if you know, one Title 19 application that gets held up, one that, you know, looks clean, but they really actually transferred some money or transferred the house and now there's a penalty period. One person that's sitting there without payment for 2 or 3 years, you know, because you won't get payment at all during that penalty period, that can be very devastating to a building. And so maybe it's just a fact of people not, you know, willing to take the risk that it looks like a clean application. And that's all I can think of, you know, it's very risky. I'm working on the conservator work group too. And one of their big issues is the time it's taking them to get a Title 19 application processed or moved. And they're having difficulty working with, you know, the banks and the financial houses to get them the information. But one of the things they're looking at is there's something DSS can do just to help with the process. You know, they can't really speed up the eligibility, but they can help people potentially be more helpful to people who are going through the process. Because think about it, someone falls, they break their hip, they're in the hospital. Okay, now they have to go to ABC nursing home. Nobody thought about this, right? Nobody understands the process. Oh, isn't Medicare going to pay for it? No, they're not. They're going to pay for 20 days. What if mom has to stay? What is a Title 19 application? This is all hitting people, right? All at once. And so it's even people that aren't intentionally trying to sneak into the system, you know, or not pay, not do the application. It's just a difficult process. So maybe there's something we can do to actually help people who are in that stage, that, uh-oh, something happened stage, and I've got to apply for Medicaid. I don't know.
It's a good point, Mag, right? And, you know, I know that there's a couple of systems, well, at least I'll just speak about ours, I'll speak about Danbury, not even our whole system, where it's so expensive from many fronts. I'm not just talking about money, right? But it's so much to keep folks in the hospital for all the reasons that we've talked about. And then more, we actually entered an agreement with a local nursing home where we came up with a daily rate. So when a patient is medically ready to be discharged, does not need to be in this facility anymore, putting them at risk, putting our beds at risk, right? Being able to take care of other patients, we've decided to take on the expense until that whole Medicaid application gets approved, assuming it's going to get approved, and then we, you know, get monies back to us because it's less expensive to do that than to keep the patient in the building. But that's not every hospital or health system's in a position to do that, right?
Do you remember, Jen, when eligibility workers actually were assigned, like a hospital could get an eligibility worker to work within them and a nursing home could get an eligibility worker there?
You're dating us.
I know, but it did work really well. Like it solved a lot of our pending problems back in the day. Maybe that's something we should take another look at.
Well, that's something, right? Senator Arnwar.
Yeah, so I just say that this is probably what you just spoke about is probably going to be one of the recommendations in the report. because just like when we are looking at guardianship and conservatorship, there should be an expedited process for the inpatients who are actually waiting for being at the right place for the right rehab. That should be expedited too. And a coordinator within the system would be worthwhile to have to navigate that process as an urgency. So that's something that's in the control of the state, and perhaps through policy and conversation that's worthy to look at from that part of it, at least for that segment. I just wanted to touch on another quick topic. I think broadly we can divide these entire challenges into what's happening inside the hospital and what's happening outside of the hospital. We have not necessarily touched what's happening inside the hospital, which means we have assumed that the care in the hospital has been efficient, which means that the patients who needed to have their tests done or echocardiogram or the MRI, they were done in an efficient manner in a timely fashion. The blood tests were done in a timely fashion. The consults for physical therapy, occupational therapy were done in a timely fashion, and they're not. So we lose 2, 3, 4 days into some of those inefficiencies that are in the hospital setting. So I think that's something to keep in mind. And the care coordination inside of the hospital, we talked about care coordination outside of the hospital, but on the inside, that needs to be worked on as well. I served as an advisor to the care management office, and then every time we would look at it, we'd see these are the number of days that are being lost, and we would put them as a cost to the healthcare system for minimum. It used to be like $5, $6, $7,000 a day, depending on where the patient was, to about 25,000 a day if they were in the ICU. And then every time there was a delay, that would result in a huge cost, and that's how we were able to convince that that needs to be done efficiently. So that's not been in part of any of our conversations, and that is assuming that we have a system in place for the hospitals. Thank you.
But I guess just to push back on that, that was our discussion a little bit about scope. I mean, is there a way, I mean, to influence what's happening inside the hospitals from the state level that you're envisioning? I mean, that's why we kind of stayed away from that a bit.
I think because it's very tricky to go into the depth of it, because that's a world of its own. However, I think the care coordination that happens on the inside has to be spoken of, not necessarily some of the things, but it's worthy to look at the care coordination inside the healthcare systems. People do not recognize the value of care coordinators inside the hospital as much, depending on the expertise and insight or wisdom of the leader within the healthcare system. But on the outside, it's very clear, and that's there too. So most of the time, they're not looking inwards; they're looking outwards. So again, that's going to be a very big scope issue, and that will take us away from some of the things. But I just wanted to put that on the radar, that perhaps that's something that a report should be able to say, that we have not touched on this topic, but that is assumed that people will manage that too. But those inefficiencies are there.
Thank you. Tracy?
Just two more comments. Mag had touched a little bit about the risk that providers are able to take, not just willing, but able. And with HR1 coming up with changing the retroactive Medicaid payment, I don't know if you're aware of that or not, but it's 3 months currently once somebody gets approved for Medicaid, and it's going down depending on the payer to 1 or 2 months. So that's adding more risk to the provider accepting a client. And then the care coordination, the community providers, I didn't talk about that at all, but I'm sensing, since I think I'm one of the only, there's a few on here, I guess, that are community providers, but I'm representing, the larger home health and hospice. A big challenge is lack of PCPs in the community for that particular referral. They don't have anybody in the community, and then there's nobody to accept the case. We cannot provide services without having a community provider to sign our orders. So that can be a big challenge.
Thank you. Okay, just to move through the rest of the survey, we did ask about capacity issues perceived, rank issues. In other words, a lower rank would be a higher issue with capacity. and at least according to the group, behavioral health topped the list, with pediatrics being slightly higher in terms of needs than adult. Long-term acute care hospital, we have talked about that briefly as far as capacity issues in the state. Hospital is in there. I think certainly in the urban areas, we're seeing capacity issues more than some of the other outlying areas, SNFs, inpatient rehab, assisted living, and then home health care. The issues with capacity were rated primarily, or I guess staffing was more of an issue than space, I should say, is what was perceived by the group. Too much space and not enough staff. Very quickly, I did put a question in about ED boarding, because that's something I experience on a regular basis. The importance was relatively high per the group. At least half thought it was really inability to staff inpatient beds rather than hospital capacity per se. Although I would say that discharge challenges probably impact the staffing in the hospital as well, so that whether we create actual beds or virtual beds, I think it's important to get the patients out that need to be out. A few comments on that. Social admits were growing, and that regional differences, which is something that's certainly very apparent when you look at for example, the OHS report on hospital capacity and what's going on. I think we see a lot of differences depending on where you are in the state. As far as legislative priorities, the top ranked one from the group was expanding post-acute care capacity. Next was Medicaid and commercial insurance reforms. Targeted regulation on post-acute care acceptance was ranked a little bit lower. Specialized placement capacity, we've talked about long-term acute care hospitals, and guardianship and conservatorship was on there, but a little bit lower. Some of the comments on this, improving coverage options so staff can more competitively do it more in the home. Less regulation can be good sometimes, and I'd certainly be interested to hear if people have specific legislation they think could be relaxed without harm. That's certainly something we'd like to consider. And then identification of the problem. This is something, just to circle back, we did ask about data. We've had a couple responses. I know we're trying to work with CHA as well as OHS on any data they may have. So we're optimistic that we may have some of that, but it's really not that easy to find. I've been doing my best to dive into what is publicly available, and there doesn't seem to be a lot in our state. There are states that have done a better job with defining this and reporting it. So it is possible to be done. In particular, Minnesota has done a great job. I looked into that some. New York is starting to do it more. Massachusetts has started to do it more. Other items people put in the survey for the agenda. We talked about transportation, but even transportation, from discharge facilities to services was brought up. The potential for maybe a rapid deployment team. I don't know how this might be operationalized, but I see Tracy shaking her head. But in any event, and a focus on data to identify viable solutions. So we got 10 minutes left. I do think the data remains important. I'd like to hear if anybody has any updates on that in the group. Title 19 we talked about briefly. And I did mention this, but looking into what legislation is out there, I see there is presumptive eligibility for the Connecticut home care program. But this is just sort of a general slide for this. This is my last slide, so we'll pause here and open it up for discussion. I guess the first question: is there any updates on data from anyone? If not, we can take that offline. But I'll just raise that first. Take silence as a no.
I think some of the challenges with data is some of the data's on delay are manual inputs in our various EMRs, and based on to Dr. Anwar's Senator Anwar's comments, the hospitals themselves have challenges with regards to who's going to put that data in. Does it change on the weekends versus the weekdays? Changing, based on financial pressures, changing workflow decisions that are happening. And I think that's where our data is going to be gummed up, so to speak, because my data may not be the same as somebody else's. But it may not be, if there are specific areas, specific questions that we want to ask, there may be an opportunity for each one of us to go back and review in the AMR to say, okay, well, what is our data? Understanding it may not be perfect, but it may help us directionally identify things that we may not be able to see individually.
Yeah, in Minnesota, they have a category of data. Basically, if a hospital is discharge delayed more than 48 hours, it's a binary issue for the patient. They put it in the MR and it gets reported at the state level. So I agree with you. Sometimes trying to have the perfect be the enemy of the good. If you're trying to get all the detail, you may miss the big picture. But I do think there might be opportunities to try to align reporting, and I think it'd be in the interest of the hospitals around the state to get a better handle on where these delays are and which direction they're moving in for state capacity. That's just my thought. I know that there's always a hesitancy to have more requirements or have more data. I know it's a burden, but there's a reason why data can be helpful in certain situations. So I just bring that up because I know other states have made it further along in that. Marcy, go ahead.
I would just say that there are differences, but to the point of directionality, we can usually get things close enough, especially when we think about, I guess, the anticipated magnitude of what some of these delays could be, especially at an aggregate level. The hospitals are moving on this, right? It's just not their top priority. There are many of them currently going through mergers and have a lot of other very high IT issues that I guess I shouldn't say issues, they should just say topics or, challenges that they're trying to work through. So I will say that we are hearing from all of our different members that they are moving on the topic, and so that they are putting things in place and they're working through different issues that they're finding, especially as they think about how to approach changing their workflows. We're getting questions on, what if they have more than one delay? Do I count them at the same time? Do I overlap them? Do I try to do I need to go back in and say when this delay ended and then the new delay started, and these sorts of things. So there's just different pieces that need to be worked out, because as you can imagine, based on the conversations we've had here, this is a multifaceted problem, and trying to kind of pull apart the different pieces to be able to capture this in a way that makes sense and tells a story. It has been, I would say, the trickier aspect. But I just want to reiterate that the hospitals are making a lot of progress in this space. And so we've heard from many of them that they're moving forward with being able to put something in place to be able to transmit this data to us.
Great, thank you.
I think we have 5-7 minutes to wrap up, trying to always wrap up a little sooner. And it's so interesting that we start the call thinking we're not gonna stay on the line and have a lot of discussion. Yet I think every meeting that we've had, it's gone right down to the wire, because there's so much to talk about. I think just a couple of housekeeping items. So after the first of the year, Chris and I will be submitting the formal letter to ask for an extension on the report, recognizing we're not going to meet the January deadline. So we will take care of that. And I guess we could probably use a little bit of help on maybe defining or identifying for the agenda for our next meeting, since it's about a month away, given the holidays and other things. If, for example, we want to better understand the Medicaid delays, should we plan for that to be one of our top agenda items and do some homework, between now and then, to make sure we can have a fruitful discussion on some suggested things we might want to include in the report on that? And is there other data that we have to collect? Just one thought. I don't know, Chris, what your thoughts are on that as well.
No, I mean, certainly, I do think the survey was helpful for me anyway, to understand where the group, think some of the priorities and challenges are. So that certainly emerged as one of the top ones. I need to learn more about it. I'll do what I can, homework, online, but certainly any expertise we have in the Medicaid space and what the actual delays are and how we might address those, what other states have done. I think if anyone wants to step up and take a little time on the agenda to help with that, there's probably people in the group that have some of that expertise, so I'd welcome that. Marcy?
I don't know if we want anybody from DSS to come as well. CHA has been working with DSS on long-term care applications and the process. And we've been having conversations with them about what can we do to partner and kind of improve this process. They have been very willing, so I do want to start there. They are very willing and they are very open to hearing what everybody is experiencing and how they might be able to change that. Two of the things that I took away from our most recent meeting that really struck me is that the case managers are carrying workloads of 75 to 100 applications at a time. And so that one really struck me. It's how do we think about trying to move through this process more efficiently? And then the other piece that struck me is there, from the time in which the application is started, there is a 15-day window until DSS has the opportunity to send out the first request for information. And so I think there's a place for us to think through how we approach that from both sides, because my interpretation is that the hospitals see when a person needs care toward the end of their care. And so that 15-day period is largely spent with the individual waiting once they're medically cleared. And so how can, the hospitals think through, how do I start this discharge process or thinking about this discharge process earlier? And I don't want to discredit DSS's 15-day window, because if we are doing this in paper, in some cases, that may be necessary. And so then how do we think through a paper process or an electronic process, or how do we think about the improvements there? So I do think that there's probably a little bit on both sides, but I just wanted to acknowledge that they have been very willing and open, and that there are some real challenges on that side of things as well that I needed to be educated on, that I thought was really helpful.
Representative?
Thank you, Dr. Moore. And Marcy, thank you so much for those comments. And you're absolutely right that if we're going to be having this conversation, we should be having it together with DSS and to problem solve with them, and to acknowledge that, again, the federal changes that have been put upon them at no choices made here in the state are causing an extreme amount of difficulty, challenges from a staffing level, financial level. And so I appreciate you naming that. And I think it's an excellent suggestion to add them to the conversation. And I will say, our commissioner of that agency has been one of the most responsive and willing to try and find a way to get to yes within the resources that they have. So thank you for that.
Thank you. Mag?
Yeah, I would echo that. I can remember a time when there were such delays in Medicaid applications that it was phenomenal. So DSS is doing a great job, but I think it's the nature of the beast, right? It's this application, and that's when someone's coming in, not just for post-acute, but a potential long-term stay. And I think maybe we have to also realize it's kind of a hit to the family and the resident themselves. You know, I'm going to a nursing home. I might have to stay there. I'm going to have to spend all my assets, before I can even become eligible for Medicaid. It's a tough time for people to absorb this within a number of days. But maybe there's somewhere, or a hospital, either in Connecticut or elsewhere, who has developed a good social work approach to this, a good way to approach families, a good program where when people are faced with this at this time, and it's not just a placement for the hip, that maybe will work, that we could replicate, or maybe there's something there. Because I think we have to understand that it's not just the providers. It's also a real issue for the family or the resident themselves.
Yeah, no, I think everyone is doing their best, and we're just looking to try to, come together as a group and as a state to solve, problems that really affect everyone. So thank you for that. I want to respect everyone's time. Our next meeting, I believe, will be January 12th. But yeah, we'll take that suggestion and try to look into maybe if we can find somebody from DSS. Representative McCarthy-Vahey, I may reach out to you. And I know Jody Terranova was actually, I see her photo on the call. She was nominated by DSS. I don't know if she has any connections or is listening, but we can reach out offline and we'll reconvene in the new year. Thank you, everyone, for all of your help and participation, and have a great holiday.
Thanks, everyone.